morning, and thank you for keeping it Citizen Television this particular Wednesday. Health and lifestyle begins right now. A segment we usually talk about how to live a healthier life and even just basic conditions that people are battling with out there. So this particular morning, I want to take you into a very interesting world. We all know that proper care during pregnancy and even during pregnancy, delivery, and even after that is usually very important for the overall well-being of both mother and baby. But again, this has become quite a challenge, especially if you look at the numbers of maternal mortality in our country as it is today. The statistics that we have officially tell us that they stand somewhere between 400 to 600 deaths per 100,000 live births. That is annually. If you look at what the global targets are telling us, we have a long way to go before we catch up. And that is what we want to talk about this particular morning, focusing on the entire journey and just how to help mothers and even, you know, the role that the society can play to be able to help us reverse this particular trend that is becoming concerning. And with me in studio this morning, I have somebody who has been in this field for more than a decade and a half, just walking with mothers through that particular journey to receive their bundle of joy, sometimes in not so very good circumstances when they lose their children. And she will be sharing with us her expertise and experience. Her name is Caroline Mwololo. She's a nurse midwife, and she's here with me in studio this particular morning. Thank you so much for creating time for us.
Thank you so much for having me.
Yeah, Karibu. Quite an interesting journey. 16 years.
Yes, 16 years.
You have seen so many babies.
Sure, I have.
And delivered so many.
Yes.
And worked with mothers through very trying times when they lose their bundle of joy during that time.
Yes, it's a very vulnerable state for a woman and even the entire family. Yes, very vulnerable state.
All right. So this morning we want to talk about how to reverse that particular trend and ensure that we have healthier mothers and healthier babies, because that then would lead to healthier societies and the healthier nation. And when I began the program, I talked about the shocking numbers that we still are dealing with as a country when it comes to maternal mortality rates, as high as 400. Some latest reports have done that and even put it between 400 and 600. So depending on the research and the surveys that have been done. But looking at that, we are not, looking too good. Probably from your experience, what would you say are some of the major causes of these alarming numbers?
All right. So thank you so much, Safin, for having me. And as I mentioned, pregnancy is a very vulnerable state. And it is true that our statistics from the KDHS show 400 to around 600 mortalities, in 100,000 births. And we know very well that our target is actually 70 or below. And anyway, any mother should not be lost due to pregnancy or delivery. And some of the drivers that actually bring this is low socioeconomic status. You realize that there's a lot of issues around finance. And to access even the facilities sometimes is a problem. Accessibility to a health facility. For those who are staying in the rural areas, sometimes even having, a hospital where it is, which can handle even essential newborn care, especially when there's a complication, is something that is of dire need. Yes, we could be having some clinic or hospitals, but the referral system, are we able, what is the next hospital that you can refer in case of a complication? The other thing that is very key, if you look at still the KDHS, you realize that, the births up to 88%, births are normally between 15 years and 49. That is the range. But 15% is the teenagers, between 15 to 19 years. So again, age is such a big... Yes, early pregnancy. Yes, because age plays a very big role. Then, of course, education, low education standard, sometimes prioritizing antenatal care. You could be pregnant, yes, but maybe it's not a priority to you that you need to go to antenatal, you need to do your visits and go and be followed up. How early do the clients visit the facility?
Or you don't even know that.
Yes, you're already even pregnant. By the time you're coming, you know, the pregnancy has already extended, there are those what we call preventable, you know, maternal deaths or issues or complications which we can prevent just by nutrition, for example, being able to get your tetanus injection. So the earlier the woman comes to the facility, you know, the better. So those are some of the drivers, yes, which I would say are there. And the other thing, of course, skilled birth attendants. Yeah, so having competent and skilled birth attendants. The other thing is, yes, you could have the facility, but do you have the infrastructure? Do you have the equipment? Do you have the drugs? All the essentials that are required, so that when you have this mother and they've come to deliver in your facility, you don't have to even refer, for example. And if you do, you need to refer, the ambulance, how well equipped is it? So there's a lot to play around in some of the causes of this maternal death.
And some of those we'll delve deeper into as we continue, you know, engaging in this conversation. But you mentioned something around, you know, the skilled birth. Let's begin from the very basic, yeah?
Yes.
The numbers are not looking too bad. As at 2022, KDHS placed it at 98% women, you know, being attended by a skilled, you know, service provider. But then who falls under this category? We've heard of stories of Uko Kwa village, you know, the mother's there and a friend, a neighbor. So when we're talking about a skilled person, who falls under this cadre?
Yes. So thank you so much. Again, somebody who is a skilled attendant or a service provider, it means they've gone through the basic training. So for example, nursing, midwifery, you know, obstetrics and gynecology. So there's a basic training of that service provider. They have gone through the basic training, whether it was 3 years, 2 years and a half, or 4 years, they have gone through that training. And they have been working, you know, in a facility that has a maternity. They are able to perform and execute their skills very well. Now, you realize that, yes, we have clients who cannot access these services. And we have people in the village who either they're called birth attendants, or just women who have experiences.
And we have their names in our native language.
Yes.
We know them.
Yes. And you see, most of the time you would find that probably the client actually really wanted to come to the facility to give birth, but because of the challenges of finances, and maybe even some beliefs in the family, you know, you could be told all your relatives have been birthed by this particular person. So even for you, you also tend to follow the same culture or certain belief system. The other thing is, of course, if you're staying at a very far place that you cannot access this place, then the best person is this person who has experience, and probably you feel this is a person who can deliver you. And you will find most of the time, labor is a very natural process. So if there is no complication, the baby is of good weight, what we call normal labor is ongoing with the process, you actually don't need to do much. Because the baby will follow the negotiation, we call it negotiation passage, until the baby eventually is birthed. So most of the time, unless now a complication arises, that is when you will need to refer the patient. And you see, because of our old culture and our women who would give birth at home and there were no complications, and that's why they will tell you, I mean, even for you can still give birth at home. But in that dire need, or in that case where you have, for example, a hemorrhage, bleeding now starts happening.
In case of an emergency.
Yes, what now happens then? Because you're there inside the village, or you have a home birth, and you're not able to have this ambulance on time, you will lose this mother, because we know bleeding will definitely lead to shock, eventually lead to maternal death. And if not that, if the baby, for example, come also with a complication and needs resuscitation, this is a baby you will also lose very fast. Or if you don't lose, the baby will have complications in future. So that is why we are saying that it is important to go to a skilled birth attendant or a service provider who has been trained, has gone through the basics of training, nursing, midwifery, obstetrics, gynecology. Yes, this is a person that you need to go and attend to.
All right. I'm also trying to look at, you know, the issue of going for ANC.
Yes.
What is the recommended, way of doing it? How many times? And, if you look at even what the numbers are telling us, there's still a lot that we need to do in terms of how many women are going for these, services.
Yes.
Let me just run you through some interesting numbers. The percentage of women who had 4 or more ANC visits in the last live birth, that was at 2022, continues to increase for those who have some level of education, but it is declining for those who have no basic education. For those who have education, of course, those mothers, it increased from 49% to 83%, but we're still having a very big challenge with the mothers who do not have any level of education. If you look at the disparities in terms of geographical location, the percentage of women with 4 or more ANC visits for the last live birth is higher in urban areas at 74% compared to those in rural areas at 62%. And these are issues you are raising as you talked about that. But then, even as you interpret these trends, what education and geographical location has to do with ANC visits, also tell us why it is important for any pregnant mother to really take this seriously. Okay. How many sessions probably are recommended? So
the average session that is recommended is actually 4 visits. And we normally say you can start your clinic from 16 weeks. So there's what we call a FANC, or a focused antenatal care, whereby we bracket. So 16 to 20 weeks, that is the first visit. Then from 20 to 24 weeks onwards. So at least 4 visits, a visit that we can say it's quite well recommended. Now, during those visits, we are checking your blood to check your HB level, which is very critical. Because if you have anemia in pregnancy, it will still lead to bleeding, and eventually more or less other complications will arise. Again, we give folic acid, which is a supplement to necessitate the pregnancy and the baby who is growing. Remember, the baby needs to have folic because of the neural tube issues. So if they don't have folic acid or folate, then they may end up having the neural tube defects. And that is one of the things you're really trying to prevent. You'll be educated about what to look out for, the danger signs, When are you supposed to come back to the clinic? When are you supposed to come for your next visit? Tetanus injection is normally given from that 16 weeks to 20 weeks. Because you realize tetanus, once the baby has tetanus, it is a very bad condition. You do not want even for your worst enemy. Yeah,
but then just because you've mentioned that, probably one would be asking, how is tetanus, coming in this whole process? What causes it, and at what point does the baby receive it? What circumstances? So majorly during birth is when the baby will probably get tetanus. You realize that there is a cutting of the cord. You need to use a blade. Yeah, you need to be able to separate the cord from the mother, the placenta, and the baby. So all that process can lead to tetanus. Tetanus is it's more like a bacteria that can be found anywhere. So tetanus in itself, as you're injecting the mother, it's the baby who is benefiting. But even for the mother, in case she gets a cut, during her process of pregnancy, she gets a cut from a rusted thing, or she gets anything, you want to prevent the baby from getting any tetany or tetanus infection. So we normally do 2 doses in the first pregnancy. So between 16 weeks and 20 weeks, you get the first dose. Then after a month, you get the second dose. Then every other subsequent pregnancy, you get only 1 jab. So again, it starts from 16 weeks on. Now, as I go back to antenatal clinic and why it is important, you see, sometimes you might assume that the baby is fine, but even just doing that ultrasound will be able to tell you, is the heart condition of the baby okay? Is the formation of the baby fine? Remember, we want the baby to grow both in mind, body, and soul. This baby has to grow as a whole. Same to this woman who is here. Now, unless you do some tests, like doing a test like the scan, being able to do a scan, you will not be able to know how the baby's growth is. But doing the scan, you can be able to tell if there is what we call low birth. The baby is having either intrauterine growth retardation, so the baby is not growing to full birth or full growth during intrauteral stage.
the only way you can do that is through a scan. Now, for example, if you come to the clinic today, I will check your fundal height. I will be able to check and assess. Today, you're 20 weeks. There's a certain expectation I have that this baby should have reached a certain...
There's a standard set, yeah?
Yeah, an estimated fetal weight, an estimated growth that I'm expecting a weight increase that I'm anticipating for. So when you come to the clinic and I check your weight and I'm seeing your weight is not increasing, your weight is actually going down, from the fundal examination and palpation, or rather checking, I am seeing that the baby is not growing the way I would have anticipated. Then that is a cause for alarm. And quickly, you can be able to take the patient for a scan, and you can see that maybe there's some growth restriction. Again, diabetes, we have what we call gestational diabetes, which normally come in majorly during pregnancy, or hypertension, yeah, which just occurs during pregnancy. There are those who suffer hypertension away from pregnancy, but there are those who get gestational hypertension or gestational diabetes because of the pregnancy. So how else will we learn this unless you come to the clinic? So it's very important for any woman who's pregnant to come to the clinic so that you get all this information. And for us, even as healthcare workers, we also need to go to the village. We need to go to the community. We need to educate them, like what we are doing right now. You know, using social media, using TV station, even in the local languages, so that the women can understand that it is very important. The other thing is autonomy. Sometimes, especially in the village, the woman doesn't have the autonomy to make decisions.
For herself.
For herself.
Including even decisions about her reproductive.
Exactly, yes. So it's very important also for the woman to be given autonomy to make decisions, because she's the one who's carrying the pregnancy. She's the one who understands her body. So today she can feel, I don't feel the baby is moving, yeah? Or the baby is not moving the way I've been used to. That is something that should take you back to the hospital. But there are people who will say, you may be tired, you need to rest first, and then you'll go to the hospital later. By the time you're coming to the hospital, things have already escalated too much. Yeah, so that autonomy is very important. And of course, maybe also just finances, making sure that these women have something with them, so that even as they come and they're told, maybe we're not able to do an ultrasound here, but we're referring you somewhere else and you need to pay maybe 1,000 or something, they have that money and the scans can be done.
All right.
Yes.
I just want to take you back on something that we mentioned earlier concerning, the factors that would really affect or have an impact on access to, some of the services that you're recommending. For instance, the financial muscle of a woman is really a factor. You can talk to us about the dynamics and why this would lead to, some numbers really dragging. Talk to us about the geographical location. Those who are in the urban areas are reported to be doing better, even in going for ANCs compared to those in the rural areas. The level of education, those who've gone to school or achieved higher levels of education are reported to be performing better. Somebody would ask, what does finance, location, and education got to do with pregnancy?
Yeah, very good question. Now, you realize that anything about actually just going to the hospital, it requires finances. I know we have Linda Mama. I don't know how much it is working right now. I wouldn't be able to give the statistics, but I know those were some of the things that were helping so that the women would deliver in the hospital. For you to be done a lab works test, for you to be done an ultrasound, for you to receive, maybe just the initial care, you will not be charged. Probably the only charge you'll get is just registering, maybe a 20 bob or 50, depending where you are. But the other tests that follow up, then that one you need to pay. Most of the time you need to pay. And that is why finances now come in. Because if I don't have the money, I will not do the test, even though I would really want to do the test, but I don't have the money. So I will end up just continuing with clinic or just coming, but pushing forward, postponing, procrastinating or postponing, which can really be detrimental, because the initial phase of pregnancy is very key, because you want to do everything from the initial phase. So finances play a big role. Education, do you understand what pregnancy is? Do you understand the implications about pregnancy? Do you know about the danger signs, for example? because when you have the knowledge and the knowledge about something, you would want to follow it up. But when you don't have the knowledge, then you can easily ignore, because I mean, you have seen other people carrying a pregnancy and just giving birth without any complication. But when you know that there are some incidences that can occur, that 1 out of maybe 10 you could get a complication, then you would go to the hospital and make sure that you've gotten the right treatment. So education plays a key role. So understanding that this is very important. The other thing I will talk about is sometimes also fear. There's the fear of unknown. You're just scared. You don't know if you go to the hospital what you'll be told. And probably you've also seen in your family there are some complications which have followed. And so when you get pregnant, you're like, if I go to the hospital, am I going to be told this is the same thing?
So you'd rather...
Yeah, so you would rather, let me just stay until the time for until the time of delivery. Then you go and receive your baby with hope that everything is gonna be okay. Yeah, so those are some of the things I would say that are very critical. And of course, when you learn about ANC or why it is important for you to go for these visits, because it's not a waste of time. There are people, of course, because of accessibility, as we have said, that the clinic is so far from where you're staying. You have to wake up so early and walk a distance for you to access the facility. Then you're like, okay, if you don't understand the importance, you might ignore it and just wait. So it's also important for us to make sure that even in those villages, we have brought the services closer to them so that they can be able to access the services. Again, the referral system, very important. That yes, I am in a clinic, I'm in a level 2, and I know very well that I cannot handle an emergency here. At what point are you referring this client to the next facility? Then maybe the last thing is, yes, I could be actually in a very good facility, but do I have all the equipments that are required? Do I have all the drugs that are essential for me to be able to conduct this birth without any issues? If it is a normal birth, normal pregnancy, everything will happen well. But just in case of that one incident or two where you have a complication, then you need to be ready for that.
I'm looking at all that you're sharing, and seems like there's a lot of planning and decision making that goes into this. So when you talk to women or couples, because that's the trend right now, what do you tell them in terms of when planning for pregnancy starts? Does it start when you realize that you're expecting a baby, or what do you need to do so that things like what you're saying, you know, even knowing which hospital does it have the facilities, actually are factored in that particular plan? When does it begin and what does it entail?
So maternal health actually starts before pregnancy. So that's why when you're in the urban area, you're actually educated about pregnancy, you would actually start what we call a pre-clinic, let me say pre-clinic. So you start the clinic early, you're told about your nutrition, and you start by saying that I want to become pregnant, maybe in the next 3 months or 4 months. Anyway, you know, it's God who decides, but that is what you're planning. So you tell yourself, because I want to become pregnant, there are some essential things that need to be done. So you go to the hospital, you see a gyna or a midwife. They will take you through what you need to eat in regards to nutrition. You will be done some tests like HIV, syphilis test, you know, the basic test, hemogram, how is your HB level. So you start boosting whatever issues you're having even before you become pregnant. Yeah. Then once you become pregnant, the first time you realize that you're pregnant, you've missed your periods, then you need to go to the hospital so that you start the antenatal clinic as soon as possible. Yeah. So that is something that is very key. So we always start advising the couples, or start advising this woman, start taking care of yourself even before you get pregnant. The moment you realize that you have that desire to get pregnant, then start your clinics from then. Come to the facility, we will talk about nutrition, we shall talk about, we shall do your test and run test. We see if you're having any issues in regards to HIV, syphilis, hepatitis B, some of the things that are very critical, especially when you're pregnant. Then we'll be able to discuss even the danger signs during pregnancy. Now, danger signs, we normally talk about them because those are the things that should make you come to the hospital as soon as you see them. So for example, bleeding, anytime you see a bleeding during pregnancy, that is something that is abnormal. You need to come back to the facility. In case of drainage of liquor, yeah, anytime within pregnancy and you have not reached 37 weeks, then you need to come to the hospital, yeah, because that could set it an infection, or you could be having what we call a preterm delivery. So it's very important to come. And remember, we can be able to do something when you come to the hospital, because we can give you some injections which can mature the lungs of the baby, so that in the event that the baby is born, the baby will still be born in a way that they can still breathe on their own without so much issues. The other thing that is very key, if you're having dizziness, you're having severe headache, that could be a sign of very high blood pressure. So you need to come back to the hospital. Again, anemia, that is your low, if there's low HB. So as you come to the hospital, we do what we call a birth plan, yeah? So birth plan, we will take you through the pregnancy journey. These are your anticipated visits for the clinic. These are the drugs you're supposed to take during antenatal. This is nutrition. Then we will ask you, because it's the client who decides which hospital do you want. She could be coming to me for an NC clinic, but she doesn't want to deliver in my facility, for example. So you ask the client, which is your preferred place of delivery? You indicate, it's like a checklist that you're going through. So this is a facility you would want to go through to deliver. The other thing is, do you want to be delivered by a midwife? Do you want a gynecologist? That is indicated. When the baby is born, do you want your spouse to cut the cord, or do you want us to do it? Yes.
Okay.
Yes. Do you want to hold the baby first, or do you want us to pick the baby? You know, it is, we are discussing, because you need to plan together. This is what you want. This is the birth that you want. Yeah. Then we have what we call Lamaze classes. We have what we call physio classes or Lamaze classes, where we take you through education in anticipation for breastfeeding. How are you going to breastfeed your baby? The positions that are there in regards to breastfeeding. We check your breast and see, are the nipples inverted, or are they okay? If they're inverted, we start doing something from there. Yeah.
Oh, okay.
Yes, because those are the things you start doing before the baby comes, because when the baby comes, they'll become frustrated. Yeah, and when they become frustrated, it's so easy to go to maternal blues or even maternal depression. I don't know if you're a parent. Myself, I am.
I am a parent.
And there are times when the baby is breastfeeding, even then when you know the position and everything, it can be very painful. So you can imagine this woman who does not even know the positions or how to assess and see if the baby is breastfeeding well. They'll end up with a lot of cracks or engorgement, which are things which are very much preventable.
Not a very good experience,
it's supposed a painful
to be, experience.
And
it's supposed
it's
to
a very nice experience. Otherwise, you'll be seeing the baby waking up and you want to run away, because the pain is so much. Yes.
Let's talk about, you know, how you handle, for instance, first-time mom, second time, and women who have shown indications that there could be complications, or they're having a complicated pregnancy. How do you handle these three different cases?
So, of course, for a first-time mom, it's very important to take them through everything. That is, you know, anyway, all pregnancies are different. Let me start with that.
So every time is almost
every
like the first
pregnancy,
time.
yes, is very different, and the approach is very different. There are times that the woman will come very excited, maybe the first pregnancy. Maybe the second pregnancy was an oops pregnancy. And there are others which actually you are even on a family planning,
and God surprises you.
Yes, God surprises. So every pregnancy is very unique. So you handle every pregnancy as a unique pregnancy. But of course, it's very key for you to talk to this first-time person, because there's those fears that they have, the fears of unknown. They've never gone through a labor process. They've never gone through a delivery. So for them, it is a very gray area. So when they come here, you need to tell them everything they need to know in regards to essential baby care, in regards to herself, what she's supposed to eat, what she's supposed to do, how does she handle herself, all that is very key. The clinics, how soon can she be coming? Is it after every month? Is it after every 2 weeks, dependingly? How is, the general condition, the psychological aspect of it is very key. You want to understand, are you ready for this delivery? Are you ready for this baby? Talk to the couple. Is there support? Is she getting support from home? Is she being able to make decisions and all that? So a first-time mother, you would want, of course, to just be a bit patient with them. And you would want them to ask as many questions as possible, so that you can address them, all of them, and don't feel offended. Even the questions that you feel like it's so obvious, to me it can be obvious, but to them it's not an obvious case. So you just handle the questions as they come. For a woman who's already given birth, most of the time they will tell you, my last pregnancy was like this and like this. Even the delivery took a very short time, or it took a very long time. There's a certain anticipation they already have because of the experience they had. So for them, it is recapping and recapping and recapping. You remember? Yeah, so during labor and delivery, this is what happened. We could anticipate for this, but in case it doesn't happen, still this is still within the normal range. So you're still reminding them and recapping back. And as I said, every pregnancy is very unique. So you handle the pregnancy as it comes. Then for what we call now the high-risk pregnancy. Now the high-risk pregnancies, these are women who have probably cardiac condition, hypertension, diabetes, any other condition. Now these are women who need close monitoring. So their follow-up will be much closer, and you'll find probably they're not just being followed by a gynecologist or a midwife. There's also maybe a physician, a cardiologist as well. So they'll have more than probably 2 people who are following up this patient.
All right.
Because you want to really take care of the whole, a client as a whole.
All right. All right. So there's an interesting thing also I want us to talk about. We've mentioned couple quite a bit, and nowadays most health facilities are encouraging mothers to come with their partners if they can when they're coming for some of these visits. I want us to talk about the significance of that involvement of the father, because we are coming from a background where this was treated as a woman's affair. You go to clinics, family planning is a woman's affair, the pregnancy is a woman's affair, taking care of a baby is the woman's affair. But this is slowly changing. I want you to talk to us about, the significance of this transition that we are witnessing, and whether we are getting value for having men on board in this particular journey.
Yes, so male involvement is very key. You realize that a baby was not conceived alone in the first place. Yeah, so it's very important for this man to be there and support the wife. Pregnancy is normal in itself, but there are so many things that happen. We have the minor things that happen. For example, you just feel like throwing kutema mate. You just feel like you want to spit all the time. There are times you feel like there's some taste you don't like. Onions are being fried somewhere and you just feel you don't want those onions. There are times that you feel like maybe because of calcium issues, you feel like you want to eat some soil or calcium, the stones which are there. Now, until this man comes to the clinic, he will not understand this behavior.
Why you are doing
He will wonder, what is happening? What has just changed? Exactly. You want to finish everything, yeah? Yeah, so they will understand and they can be able to tell, to support this woman.
Yeah.
When I'm telling this woman, I want you to eat foods that have folic acid, for example, very leafy green vegetables. I'm telling them organ meat like liver, kidney and all that. This man will understand why this is being cooked in the house. Probably they don't like liver themselves, or they don't like
Or they're the ones who have the purchasing power.
Yeah, exactly. They're the ones.
Liver is needed.
So they're wondering, why are you asking for liver every day? Yeah, but when they come here, they'll understand why you're saying this is very important. Yeah. We are telling her to eat oranges, eat fruits, And again, this is a person you need to go and he's left you some money you need to go and buy, and you decide you're going to buy fruits, and maybe you were supposed to buy other things. So those key things, again, in regards to finances, you need to prepare clothes, you need to prepare for this baby who's coming. It's going to be a whole change. It was just the two of you. I know there's this baby who's coming, who will be crying at night when you're supposed to be sleeping, who will need support, in breastfeeding, attachment and everything. So that social support is very key.
So men have a role to play. What role is that? Most of them usually feel like they're very helpless. There's nothing I can do. You know,
even
so what can I do if I am a
imagine
man?
even just changing the baby? Do you know that 5 minutes makes a lot of difference? For example, the woman has been up the whole night with the baby, and the husband takes the baby and tells the woman, just rest, because it's very important for her to rest. Remember, breastfeeding is a lot of psychological. Everything is psychological, by the way. So if she's resting and she's peaceful and happy, this breast milk will just flow. So when you tell the man, you know, support the woman, you can just even change the baby, hold the baby for a few minutes. There's that even bonding that is very key. Remember, when the baby was in the tummy, they've already bonded with this mother so much. And that is why when they hear the sound of the mother, they just automatically smile, because 9 months they were in their womb. Now this father also needs to be recognized by this baby. And so even when you give the dad the baby and they can hold the baby, bond, they start creating a certain relationship. They start, you know, nurturing. Remember, the dad is also the priest of the house. So he's the one who's supposed to pray over the child, be there to support the home. So the man has a very key thing. In regards to labor and delivery, you need the man to help you rub your back, I mean, you need somebody to be there with you. Sometimes there are people who prefer a different, you know, birth partner, which is okay. But you can imagine if your husband appreciates the pain you went through or the process that you went through during delivery, I believe they'll appreciate you better because they have seen the transition that was there. So rubbing your back, giving you water, supporting you when you're walking around. When we are saying that you need to walk around, you know, they'll support all this. So it's very important for this man to be here. Again, when it comes to the testings, like the NC profile, we normally test for hepatitis B, we check for syphilis, HIV. He's also part of this. We need to check as well because we don't want cross-infection. And if at all there's an infection, for example, HIV, then we start from there. How are we going to protect this baby from contracting this HIV? How do we prevent this woman from further reinfection? How do you also prevent yourself, you as a man, from getting further reinfection? So it is very key for this man to be there from the initial phase all the way to delivery and even after delivery.
All right. Now that we are talking about the men, and this was a question somebody sent me to ask you, let's talk about how couples should manage their intimacy during this time.
Yes.
Yeah, because mambo inakuanga ngumu sana during that particular time. Yeah, and when should it stop? Is it recommended that it should stop?
There is no stopping. There is no stopping.
Yeah.
The only reason or the only thing that can make you stop is if at all the woman has what we call a low-lying placenta. Yeah. So if the woman has a low-lying placenta, it's called a placenta previa, then that is the only time the doctor will tell you that conjugal rights here, no, we'll wait until delivery. Again, it is graded from grade 1 to grade 4. Grade 4 being it has covered the whole cervix. The placenta is attached on the cervix. And so anything might bring to severe bleeding. So there's a woman who cannot have sex throughout pregnancy until they deliver. But for any other woman who is in normal pregnancy, there's no issue.
Want to watch excuses?
Yeah, stop excuses. It is supposed to be, you continue.
Yeah.
In fact, I think it is, I don't know if it's a study, but I know there are women who've told me that actually what induced them to go into labor was actually that process.
Okay.
That during that process, then they just went into labor. So if you want induction, natural induction, you have reached 38 weeks.
Usiwache
continue.
All right. So let's talk about, you know, during that particular time, you've walked this journey, you've elaborated for us so well, and now you're almost due. So what do you tell the women to do in terms of planning and preparing for that D-Day? Yes,
very important. So when you get to third trimester, which starts from, I can say, at least when you're 33 weeks onwards, and especially when you hit your 36 weeks, 37 weeks, then it means from 37 weeks, actually complete 37 weeks, you're due anytime. You can deliver from 38 weeks, 39, 40, or even after 40. So during that time, that is the time that you still have some energy. You shop, we call it shopping. You go and shop the hospital that you want. Visit the labor ward. visit the delivery room, see the coach, the delivery coach, appreciate the process, yeah, and what you're anticipating for. So that is part of planning. Then you can make a decision and say that I'm going to deliver in this facility. The other thing is you can decide, do you want your husband to be your birth partner? Do you want somebody else to be your birth partner? And whoever you decide, inform them so that during that time they are, you know, they're standing ready.
Standby.
There's also doulas. You can also get a doula. The other thing is you also need to start preparing the clothes that you want the baby to have. Which clothes do you want the baby to be discharged with? You know, women, we have some preference. You can say in ile tu ya hospitali. You know, this is for the hospital to show that even the photo that will be taken is a remembrance or something. So those significant things that you want, pack those things. Be ready with your bag. You can imagine if labor happens and maybe you're at work and you didn't do your packing. And then you're telling, and now you're telling your husband, get that green dress. They'll bring you a blue dress or a, you know, color is also another issue. So you pack your things. What do you want? Find out from the hospital, do they give us, for example, pads, sanitary pads? Do they give diapers to the baby? Do they offer clothes to the baby? If not, pack those things ready. The hospital that you're going, get acquainted with the doctors that are there, get acquainted with the midwives that are there, familiarize yourself with that place so that when you're going, it's not a shock or such a new place for you, you're feeling so scared. And, you know, anxiety can bring a lot of issues, your pressure goes up and all that. So familiarization is very key. Then, of course, be very close to that facility. If you know that you're going to deliver, let me just use an example of Aga Khan and you're staying in Syokimau, you need to know, how am I going to be transported to this facility? Will I use a taxi? Will I use an ambulance? And if you're going to use an ambulance, do you have the contact? Have you already spoken to them?
And is it important to also have a plan B just in case?
Yes, it is very important.
You may have
because
your preferred choice, but
yes, very important. You could be in Syokimau, you want to go to Aga Khan, but the contractions and the labor, it's coming very fast, what you call precipitate, and probably you will not actually reach Aga Khan. Then you can go to the next available place. So it is good for you to know the different places that are around. This will help you even in planning so that, you know, in case anything happens, I'm not able to reach this place, I can go to this other place.
There's this concern that is coming up quite prominently, Kwanza, when it comes to private facilities. Is this notion that they prefer, you know, recommending a C-section even when it's not necessary. That's one. Number two, women are also in fear of the pain of natural birth, are increasingly choosing to go the C-section direction. Talk to us about these two types of, you know, giving birth and at what circumstances is C-section recommended.
So let me demystify.
And is it true that private
let me demystify because I worked in a private hospital for a very long time. And I can honestly say the decision to go for cesarean section was purely on medical grounds. That the woman has had prolonged labor, the woman has had obstructed labor, there was a cord prolapse, there was a complication that necessitated the cesarean section. Yes, I agree that with the rising trends, most women do not want to undergo pain. And because of maybe past experience, there are those who, the first baby, they actually went through a normal birth, but the second baby, they say, hey, it was so traumatizing, let me just go through cesarean section. And the notion is cesarean section is not as painful as labor, But you see, the problem is labor stops immediately the baby comes out. That pain just disappears. The only thing that will be managing pain, you know, is just the cramping because of the contraction of the uterus coming back to, you know, to its normal state. But for a woman who's had cesarean section, we'll be nursing a wound, Sometimes, yes, you can see the outside looks like it is okay, but the inside, there's still a wound that we are nursing. And so, until you understand what cesarean section is, then you can make the right decision. Otherwise, people think, I'll nitalala too, you know, I'll sleep, then I wake up, or I'll be given some anesthesia, I will not feel anything. Your
bundle of joy and go
Ask
home.
The women after cesarean section, you know that even 1 hour or 2 hours after, if the pain is not well controlled, that pain can be very massive. Even just getting out of bed can be crazy. Even going to the washroom can be something that is very painful. So it is very important, even as we think about normal delivery or normal birthing in cesarean section, what is the indication? Remember, if you have the first cesarean section, the subsequent deliveries will tend to be cesarean section. 1 out of maybe 10 or someone, maybe they may do what we call trial Oscar and actually succeed, especially if the baby is small. But if you have already had the initial cesarean section, high chances 80% that yes, we'll have a repeat.
Because of time,
section.
maybe one day we'll talk about those, just how the different types of giving birth, and what they entail. But because of time, as we are just winding up, let's talk about post-delivery. The under 5 mortality rate stood at 41 per 1,000 in 2022. We are showing that we're improving, because in 2003 it was at 115 per 1,000 that were recorded. This is according to the KDHS survey. But then we are still doing very badly when it comes to what WHO is targeting. That is 25 per 1,000 as at 2030. So we still have a long way to go to catch up. As we wind up this conversation, probably talk to us about what leads to the high rates of children dying at that very tender age, and how can the mother and even the whole social circle, the people around the mother, collaborate to ensure that we reverse this particular trend in terms of numbers of children we are losing.
Yes. So with a perinatal death, it actually arises from, you know, the initial birthing process. Number one, if the baby had, if the mother had a prolonged labor, for example, and this baby actually got very tired, what we call, before they were born, what we call non-reassuring fetal status. By the time they were being born, this baby was already tired. They get into what we call maybe asphyxia. They're not able to breathe very well. And so the baby is either put on oxygen or the baby is taken to an NICU facility. Now, if you have a facility that does not have a NICU, an ICU, where this baby can be nursed, number one, that is a danger, because this baby will not receive, we call it the golden hour, you know, that 1 hour after birth. That baby, if they don't receive the essential newborn care, this is a baby who will be at risk, maybe even now for the rest of their life, yeah? So the referral system, where are we referring this baby? Number two, if you have a NICU, does it have the essential drugs that are required for this baby? For example, a baby who's come very premature, and this baby requires what we call surfactant. Surfactant is, can I say, the fluid that holds the lungs so that they don't collapse. You don't have it. It's a very expensive drug. I know private hospitals have. What about the other places? Do they have? Which is normally given to the baby through, you know, you intubate and then you give the baby. If that is not there,
you may lose
this baby. So that golden hour, yes, it's very key. So some of the causes are very a premature baby. This is a baby who might, you know, neither here nor there. Of course, by books, we know that a baby who can survive very well is from 28 weeks. But what about a baby who's been born 24 weeks? If it is born in a facility that can be able to cater for this, and the weight is comparatively a good weight, is a baby who can survive. But in a place where you don't have essential newborn care, this is a baby who will not survive. Then, of course, what I've talked about, asphyxia. So the baby comes, but the oxygen saturation is very low. So the lungs have either already collapsed or we are having issues with the breathing. This is a baby who you need to monitor very closely. Then there are babies who develop what we call jaundice. Jaundice can either, it's the yellowing of the eyes. So this can be either within 24 hours, which we call it pathological. So there's an infection that has been involved, or physiological, which comes from 24 hours on or 3 days going forward. Now, if this woman does not realize, she didn't come for the clinic, she doesn't know yellowing of the eyes, or maybe she saw someone with yellow eyes and for her it's normal.
It was okay.
It is not something alarming. Again, this could be a very big risk factor, because the jaundice normally affects the liver, and it escalates to the other, you know, major organs. Again, babies who are born with complication, for example, the neural tube defects, as I was talking about, spina bifida, a baby who's without the head, we call it anencephaly. You know, the neural tube defects can be very traumatizing, number one, and very bad. So these are babies who need a very placed with a very essential newborn facility where in case they have these complications, they can be taken care of. Yes.
Unfortunately, we've run out of time for this conversation, like we always do, but shows that really the conversation has been quite informative. And of course, we just put a comma, should be picking it up in the near future, and just talking about the overall health of both mother and baby to be able to save as many women as we can. Actually, no woman should die while bringing forth life to this world. It's an unfair death, if you ask me. And no child is supposed to die before they really maximize their full potential in this world. Why would you be born only to die immediately after? It's also an unfair death, if you ask me. There's a lot that can be done to be able to reverse the numbers that we see that still remain high in our country. And thank you so much for creating time for us, Caroline.
Thank you for having me.
Important conversation. Caroline Mololo is a nurse midwife, and of course she was just sharing with us insights on maternal healthcare. And thank you also for watching, and we really appreciate your time and company. My name is Safina Chengoma. It's a wrap. Have a lovely day ahead.